We are listening. A grievance redressal model for tertiary and secondary level hospitals in Andhra Pradesh. In Andhra Pradesh, tertiary level teaching hospitals are fairly big. They range from 10 beds to 1200 beds. The patient's flow is quite high and the hospitals sometimes have to create 20% extra floor beds or makeshift beds to meet the demand. As a result, these hospitals are usually overburdened and tend to become less accountable, responsive, inequitable and inadequate. The hospital staff is generally hard-pressed for time and tend to be insensitive to the patient's needs. Most of the patients are not only poor but also illiterate and face the brunt of this problem. A major health sector reform program led by the government of Andhra Pradesh, funded by Department for International Development (DFID) with technical assistance from FHI, ensured a platform for community-centric reforms in the health sector. One such initiative was the setting up of a grievance redressal mechanism at the Gandhi Hospital, a tertiary-level public hospital in Hyderabad. This was meant to create an institutional mechanism for addressing issues of accountability and responsiveness in service delivery within the hospital. FHI supported the government to design this initiative and establish it in Gandhi Hospital. The design team first conducted a survey to assess the needs and also to find out the difficulties the rural poor face while accessing such hospitals. Inpatient and outpatient grievances. Prolonged waiting period for admission. Non-availability of doctors and nurses when required. Harassment by security staff. Poor condition of toilets and bathrooms. Poor quality of food supplied. Lack of facilities for attendance. Non-availability of wheelchairs and stretchers and staff to operate them. Long waiting at OP. Delays in getting X-ray and tests. Rude behavior of staff, nurses. Delay by doctors in attending to patients. Money to be paid to jump the queue. Demanding of bribes by some staff. Non-availability of medicines prescribed. Absence of information on complaint process or unaware of grievance redressal procedure. It was found that most people tend to feel lost without information about services available and by the unresponsive behavior from the hospital staff. The next step involved setting up of a 10-member grievance redressal task force within the hospital. The superintendent of the hospital was the chairman of the task force and RMO the convener. Ramananda Tirtha, a voluntary organization, was identified to set up a help desk in the hospital. This was a critical aspect of this redress model. Several sensitization workshops were conducted to explain the draft model to the hospital staff. It helped them to understand about the grievance redressal mechanism and the benefits that would accrue in the long run. This was followed by a series of consultation with nurses, doctors and administrative staff. As a result, the final design of a grievance redress model unfolded. Help desks at inpatient and outpatient blocks of the hospital were set up. These were manned by help desk assistants and a supervisor. They were primarily trained to provide information about services available in the hospital, floor-wise information and telephone numbers of doctors and other hospital personnel. A citizen's charter was displayed prominently near the help desk. The help desk served as one-stop guide regarding the hospital's services and information. The help desk supervisor, along with the assistants, helped the illiterate patients to register their grievances. The RMO and the medical superintendent were daily updated regarding the grievances received from the users. It was ensured in the design that the redress unit be organically linked to the hospital administration department so that the RMO and the medical superintendent could promptly look into each grievance. The RMO categorized the grievances in the following manner: to be addressed at hospital level, to be addressed at health department level, larger systemic issues. A nodal officer identified at the department level processed the grievances. He discussed larger systemic issues with the principal secretaries. The redressal mechanism enabled the hospital authorities to get feedback about the major difficulties that patients faced while accessing hospital services. The lessons learnt were: setting up of task force proved to be one of the major forces behind the success of this initiative. The hospital administration and the staff needed to internalize the benefits of a redress mechanism. It is important to involve the clinical department right from the beginning. A strong leadership from within the hospital system is required to institutionalize such a redress mechanism. This kind of leadership serves as an effective change agent. The success of this initiative has enabled the government to decide on establishing a similar redress mechanism model in other public hospitals, including tertiary, district and primary health centers, with some modifications. Tertiary level public hospitals in India are mostly accessed by the vulnerable and the poorest. As a result of lack of responsiveness and accountability in such hospitals, the poor are sometimes forced to go to private hospitals that are unregulated, expensive and of variable quality. As a result, they tend to borrow from private moneylenders or mortgage their assets to meet health emergencies. This, in turn, leads them to indebtedness and puts them at risk of falling into the poverty trap. Setting up a system like this can be a step towards empowering the poor to access healthcare facilities in government-run tertiary-level hospitals without any problems. Access to responsive and accountable healthcare within public health systems is the right of any citizen. One of the mechanisms to ensure prompt and effective service delivery within public hospital systems is through setting up robust administrative feedback systems.